Good evening, everyone. I would like to invite Dr. Kapil Goyal, sir, who is Consultant Medical Oncologist, Rajiv Gandhi Cancer Institute, Niti Bagh, Delhi, for the meeting Overview in the Lung Cancer, which is under the Society Global Oncology Forum and managed by Healthy Blossom. Over to you, sir.
Yeah, hello everyone. Good evening. Thank you for the warm welcome. So today we have a symposium. So it is upon the lung cancer. So we'll be discussing a few things which are very pertinent in the management and diagnosis of lung cancer. Here we have some eminent speakers from Delhi NCR region. So first we have a presentation by Dr. Abhishek Raj, who is a consultant in medical oncology in Sarvodaya Hospital, Faridabad. Then we will have with Dr. Anshul Gupta, who is a consultant medical oncology in Max Hospital, Vaishali and Noida. Then we will have another talk by Dr. Rakesh Sharma, who is an assistant professor in Department of Medical Oncology, Institute Liver and Biliary Sciences, New Delhi. Then we will have a panel discussion, which will be moderated by me. And we will have our panelists, Dr. Nitin SG, Dr. Aman Chaudhary, and Dr. Raghav, who are from AIMS, New Delhi, and Dr. Sandeep Tiwari and Dr. Siddharth Pant, who are from Action Cancer Hospital. So I hope that we will have an interesting discussion in this symposium. So with this, without any further ado, may I please invite Dr. Abhishek Raj to start his presentation.
Thank
Over
you,
to you,
Dr. Kapil.
Dr. Abhishek.
Yeah, thank you, Dr. Kapil. Thank you for inviting me to the session. And I congratulate you for joining Rajiv Gandhi Cancer Institute. So I think the topic given to me is I'll try to share the screen first. Can somebody from the tech support let me know if the slides are visible?
Yes, sir, it is visible.
Thank you. So today we'll be talking about some of the novel formulations of taxane, mostly the docetaxel. The session is sponsored by INTAS and the slides have been given to me by INTAS only. So we all know that hypersensitivity is a major challenge whenever we are using the paclitaxel or paclitaxel or docetaxel. You often see that it's a big challenge, particularly somebody who is working in a private sector, who are starting any new taxol formulation probably in the second half of the day, and suddenly you receive a call from the day at 5 p.m. that okay, we have had a patient who has developed the side effect and rush back to the hospital to see that the patient has developed and is often requiring a lot of steroids and then to stabilize the patient. So some of the newer formulations have come which has tried to reduce this side effect, and we'll also learn what are the other advantages and what are some of the clinical trial data that is available with us regarding its use. So the outline of my presentation will be the challenges with the taxane. What is the nanoequivalent technology? Is it a solution? And what kind of evidence for the use of nanoequivalent technology in breast cancer? Is there any data beyond breast cancer that is available to us? So this was published in Communications in Oncology back in 2010. The usage regarding the usage of polysorbate 80 hypersensitivity reaction. So it said that in the past decade, there were reports of hypersensitivity to docetaxel. They were increasing. Around 30% of the patients develop this hypersensitivity reaction in the form of swelling, in the form of bronchospasm, in patients who have not received pre-medication. And with pre-medication also, the reported rates of docetaxel hypersensitivity is from 13% on those studies. And if we talk about this study in particular, they've said that even the patients who have experienced grade 5 toxicity in the form of anaphylaxis and subsequent death, you will see that in United States and Japan, all the patients who have had this grade 5 toxicity, all of them had received prophylaxis. Whenever we are using conventional docetaxel, So this led to the frequent hypersensitivity reactions with this cancer, despite the medication therapy of FDA to see a black box warning of the packaging itself. And we know that whenever we are using cancer, we also have with some person. The patients also require post infusion dexamethasone, not only for prophylaxis but also to reduce the swelling, cutaneous toxicity that is a cancer. We can see that because of the usage of dexamethasone steroid, there is an incidence of hyperglycemia which goes to more infectious episodes of varying grades, 29.6 and 42 and 22 infectious episodes. So basically, this study was published in Korea. It suggests that adverse events associated with prophylactic steroid use should be recognized without we should aggressively manage those side effects because of the even there is some recommendation of Indian Society of Oncology also. This was this is a recommendation from CC Oncology Indian 6 meeting that docetaxel using is associated with candidiasis. It's a manufacturer should include docetaxel associated with candidiasis and the first even the corresponding information. So what is nanotechnology? So nanoaqualic technology which was developed to make docetaxel more permeable and more available. So basically, what is LTNS? LTNS is not your railway product railway station. It is basically nanosomal docetaxel lipid suspension. It is one of the nanotechnology that is used to make docetaxel more readily available. So it is covered. So docetaxel is bound to this hydrophobic domain, and which is covered by hydrophobic domain outside, which makes it water soluble. So it's a naturally occurring, generally covered as safe lipid excipients, which is made up of this soy phosphatidyl choline and sodium polystyrene sulfate, and it also contains ethanol eliminated from this to make this more lipid soluble to docetaxel. So this is the
Sorry to disturb Dr. Abhishek, sir. There is a message coming. Your voice is not coming clear.
Okay. Hello.
It is fine, sir. I guess some network issue is there, I guess.
I don't think so. There is any network issue. I'll try to speak without my earphone and just see if it is fine. Okay. Hello.
Yeah, it
Yes,
is
sir.
perfect, sir.
Much better now. Much better now, sir.
Okay. So basically, it contains your naturally occurring GRAS lipid excipients, which is formed of soy phosphatidyl choline and sodium polystyrene sulfate, which binds the docetaxel, and it eliminates your twin AT and ethanol, which used to lead to grade 3/4 hypersensitivity reaction. It also eliminated. It was hypothesized that it will lead to the elimination of usage of steroid pre-medication. So, what are the differences between conventional and the nanoaqualic formulation? Usage of organic solvents like your polysorbated tea, chemophore, like it is used in the paclitaxel. Yes, it is not utilized in the nanoaqualic formulation. It is a completely aqueous-based system. There is no risk of leaching or plasticizer from the PVC bag or the IVC set. In conventional taxane formulation, it is there. It is not a concern here. Hypersensitivity reaction, grade 3 and grade 4 hypersensitivity reaction are not a major concern. Adverse events due to steroid pre-medication, yes, it does happen. With nanoaqualic formulation, it does not. And safety concerns like your neuropathy, there is an emerging data which suggests that probably it is associated with a lesser incidence. So it also leads to, so this nanoliposomal formulation, it also leads to the optimal molecular size. And whenever there is a tumor, there are leaky vasculature around the tumor, it leads to the easy permeation of the nanoliposomal formulation to the tumor, leading to the killing of the selective killing of the tumor cells. So this is the pharmacokinetic comparison. I'm highlighting the Cmax, that because concentration max achieved by the nanoliposomal formulation is also much higher as compared to the conventional taxotere for the docetaxel formulation, while rest of the parameters are more or less the same. So coming to the clinical trial data, this was an open-label randomized multiple dose clinical study in metastatic breast cancer for the nanosomal docetaxel lipid formulation. Commonly now it is known as docetaxel. So after screening of the patients of locally advanced metastatic breast cancer, it was randomized into 2:1 for liposomal formulation, same doses 75 mg per meter square for 6 cycles every 21 days. And it was compared to your conventional taxotere, conventional docetaxel for 6 cycles. The primary endpoint was your objective response rates. Point to be noted that there was no steroid pre-medication used in the liposomal arm. If we talk about the response rates, there was a numerically higher response rates in patients who received the liposomal formulation in form of 35% versus 26% in the conventional docetaxel. CR rates were also 4.2% versus no patient achieved CR in the conventional taxane. If we talk about the adverse event profile, again, the adverse event profile, nausea, vomiting, all grades adverse events were around 8% lower in patients who received conventional paclitaxel, although febrile neutropenia rates were almost the same. Neutropenia rates were higher with the with your liposomal preparation. Diarrhea and alopecia was almost the same. Nausea and vomiting were slightly lesser with your liposomal preparation. Serious allergic reactions like your bronchospasm, swelling of thirst were not observed with this liposomal preparation in spite of no pre-medication. Whereas with conventional docetaxel, out of those cases, out of your 23 cases, 5 cases still reported hypersensitivity reaction despite giving pre-medication. If we talk about the role of this drug coming to head and neck cancer, we know that DCF is a commonly used regimen in the neoadjuvant setting. Let's see what data says. So there is another data for your patients who are locally advanced head and neck cancer. So this was a single-arm study with patients who are locally advanced in inoperable squamous cell carcinoma, where cisplatin and 5-FU were utilized in combination with your liposomal formulation of docetaxel. The primary the study outcome was the response rates. So this was the baseline demographics. Nothing important to say here. Apart from that, if we come to the primary objective, that is the response rates were, if we talk about the response to chemotherapy, it was 64%. Stable disease was observed in 14% of the patients. We are not talking about the yellow curve because it is a response to the chemo and radiation, which was only observed in the 15 patients who underwent chemo radiation subsequently. So at 2 years, the PFS and OS rates were 82.5 and 97.5% respectively in the intention to treat population. The common side effects were again asthenia, alopecia, neutropenia, diarrhea, leukopenia, anemia, vomiting. And this is what is observed with the conventional docetaxel as well. The grade 3-4 infusion-related reaction, hyperglycemia, or neuropathy were not reported in these patients. So this also gives us confidence from whatever little data that is available that a good degree of response rate is the kind of response rate we achieve even with your conventional DCF whenever we are utilizing it in a inoperable or a locally advanced head and neck cancer patients. Response rates of somewhere around 65-70% is what is seen. So based on some of the data that is available, as well as some of the pharmacokinetic studies that have been published, now we have a guideline to use nanosomal docetaxel lipid suspension. Even not only internationally, but also now we have experts' opinion data from Indian oncologists also. So this was published in Oncology Letters as an expert opinion about novel formulation of docetaxel, paclitaxel, and doxorubicin in the management of metastatic breast cancer. So 13 oncology experts were invited, and they deliberated in the 35th Indian Cooperative Oncology Network Conference. And they decided almost 100% of the oncologists, they opined that using a novel formulation of docetaxel would add value to the management of breast cancer in the metastatic setting. Majority of expert panel members agreed that data of DLS seems convincing with respect to safety, and it can be preferred drug in diabetics and those patients where steroids need to be avoided. in a metastatic setting. So it is very important that whatever little data we have, it is available in a metastatic setting. So in an adjuvant setting, we do not have data for adjuvant liposomal preparation. So be careful when you are utilizing this drug. And we have talked a lot about steroid pre-medication. In my personal use, whenever I have used Docetaxel, the preparation which ITAS has come up with. So pre-medication, yes, I'm able to avoid, but post-medication, I'm not able to avoid because I have had rare patients who had developed grade 4 skin toxicity in patients where I did not use steroid post-medication to prevent those reactions. And those are really bad. So that prompted me that, okay, probably in a metastatic setting where I'm utilizing pre-medication can be avoided, but still low dose of steroid needs to be given after infusion to prevent the cutaneous toxicities, even if you are using the liposomal preparation. So these are some of the ongoing studies. So this is a dose ranging efficacy study in US FDA where 3 arm of docetaxel liposomal preparation have been utilized, 60, 70, and 100. And 30 subjects have been included in each of the study. Some of the early data suggests that using a higher doses led to the more response rate. The response rates with 100 mg per meter square was 48%. In the 75, it was 34.62%, and it was 21.74%. There is another study which is a phase 3 study including 657 patients. It is a 3-arm study again with a global multi-center 3-arm open label randomized study, which it is also assessing patients with locally advanced or metastatic breast cancer and triple negative breast cancer after failure to prior chemotherapy. They are utilizing the triple drug, which is 75, 100 mg per meter square your liposomal preparation versus your standard Taxotere dose of 100 mg per meter square every 3 weekly. The primary endpoint is objective response rates. 50% of completed completion of the study has been done. So this is another study that is going on in locally advanced squamous cell carcinoma of head and neck in non-small cell lung cancer patient. Plus, we have a trial going on for hormone refractory metastatic prostate cancer patients, and also in metastatic gastric adenocarcinoma patients. So, coming to my personal experience with this drug, if I have to use docetaxel, particularly in patients where other options are not available, like your prostate cancer, where I've already exhausted your newer hormonal agents, and the patient is elderly because it's a cancer of the elderly, I have been using 50 mg per meter square Docetaxel every 2 weekly, and I have noticed that the rate of adverse effects are less. Probably even the neutropenia rates are lesser, and your neuropathy is definitely lesser. It is much more tolerated. Even the mucositis that is treated with docetaxel, it is much less. And we know that the GI mucositis is a much common problem in India as compared to the West. The GI mucositis is much lesser with your Aqualib preparation as compared to your conventional docetaxel. Thank you so much. Although I did exercise a caution while using Docetaxel in a patient in an adjuvant setting. I prefer to give conventional Docetaxel 75 per meter square dose once every weekly, depending on the age of the patient, or I just utilize weekly paclitaxel. So thank you so much. Thank you for patient listening, and thank you again, Dr. Kapil, for inviting me for this ceremony.
Thank you so much, Dr. Abhishek, for the wonderful presentation. So I have a question. Like in your practice, when you give Docetaxel, sir, are you using steroid as a pre-medication and for 3 days Dexa, or you are skipping on that?
So I am avoiding steroid pre-medication because hypersensitivity reaction is something I have not seen, but skin toxicity I have still observed. I have also shared my concern with 2 of the patients, ITAS representative and ITAS medical team also. And instead of Dexa, I am using prednisolone, low dose prednisolone 10 mg BD for 3 days after I have completed Docetaxel. Because what I feel that dexamethasone causes more infectious complication when you utilize it rather than prednisolone. So I am using prednisolone as a post infusion prophylaxis of toxicity.
Agreed, sir. I think I also have the same practice. I'm also using prednisolone. So is there any other question from any of the audience? Then please feel free to ask. So if there are none, thank you so much, Dr. Abhishek, for this presentation. So Dr. Anshul is stuck on the traffic. So I'll be requesting Dr. Rakesh Sharma. So he will be discussing about management of EGFR mutated non-small cell lung cancer. Dr. Rakesh, over to you, Dr. Rakesh.
Thank you, Kapil. My slides are visible.
Yes, yes, Dr. Rakesh, visible.
Thank you, Dr. Kapil. So I'll start with my presentation, a practical approach in clinical management of EGFR mutated lung cancer. So as we all know, lung cancer is a leading cause of cancer-related mortality, although it is not the most common cancer nowadays. This data is from 2018. As per Globocan data 2020, the most common cancer is breast cancer. But although lung cancer is the leading cause of mortality. So overview of EGFR mutation in NSCLC. So in Indian context, various studies have reported prevalence of EGFR mutation ranging from 25 to 50%. And most common EGFR mutation in Indian setting is exon 19 deletion, followed by exon 21 L858R point mutation. So these mutation can be in tyrosine kinase domain or kinase activity, leading to the continuous cell proliferation. So what are the treatment options for EGFR mutated lung cancer? So we have first generation EGFR TKI, second generation, and now third generation TKI, which is osimertinib. So osimertinib is the new standard of care for the management of EGFR mutated advanced NSCLC. And it is endorsed by NCCN guidelines for the newly diagnosed EGFR mutated lung cancer or previously treated with first-line systemic therapy. Also, this is the standard of care. So, in brief overview of first, second, and third generation TKI. So, we all know first generation include geftinib and erlotinib, second generation afatinib and dacomitinib, and third generation osimertinib. So what is the difference between all these? Geftinib and erlotinib are reversible inhibitors, whereas second and third generation TKIs are irreversible inhibitors. And these first generation bind to EGFR ATP binding sites, whereas the second generation have covalent modification of ATP binding sites and HER2. And the third generation are specific for EGFR, they bind to the ATP binding site. Moving on. Also osimertinib is particularly active in T790M mutation, although it has lower activity against wild type EGFR, that is for so the trial, the landmark trial, which established the first line osimertinib is FLORA trial, which includes all the patients more than 18 years with echo performance status of 0-1, EGFR mutation exon 19 deletion, L858R deletion with no prior first line systemic anti-cancer therapy. Also, this trial included stable CNS metastasis, which was the different as compared to the previous TKI trial, which exclude CNS metastatic disease. So the dose used was 80 mg and the primary endpoint was PFS, and comparator arm include geftinib or erlotinib. So we can see this Kaplan-Meier curve, which shows that the median PFS was 18.9 months with osimertinib as compared to 10.2 months with geftinib and erlotinib. So we can see that there is a drastic difference between PFS with osimertinib as compared to other TKIs. And the difference in PFS was seen across all subgroups, irrespective of mutation status, sex, age, ethnicity, CNS metastasis. And similarly, this demonstrated overall survival, although the crossover was allowed, and the median survival with osimertinib was 38.6 months, whereas other TKI, it was 32 months. And at 3 years timeline, 28% of the patients were receiving osimertinib, whereas other TKI patient only 9% were receiving other TKI. So time to subsequent treatment, in osimertinib arm, it was 25 months, whereas in other TKIs, it was 13.7 months. I think this is covered, as we can see that the best PFS benefit was seen with osimertinib only as compared to other TKIs, which was in the range of 10, whereas with dacometinib, it was 14.7 months. And then as I have already highlighted, the benefit was seen across all group, although there is a disparity in overall survival in Asian population and L858R mutation. So this trial established that osimertinib is the first, should be the first line treatment for EGFR mutated NSCLC. A brief overview of first generation TKI. The median overall survival in retrospective data reported from Indian setting is from the range of 6 months to 21 months with first generation TKI. And with osimertinib, another trial, Archer 1050 versus Flora. In Archer trial, dacometinib was studied and compared with geftinib. So in this trial, patients were stratified as per the race of the patient, and primary endpoint was overall, PFS was the primary endpoint. And in Flora trial, there was no, moving on. The point which I highlighted previously is that in Archer trial, patients with brain or leptomeningeal metastasis were excluded, whereas in Flora trial, patients with CNS metastasis not requiring any steroid, means stable CNS metastasis, were allowed. So this is the first trial to study the role of TKIs in CNS metastasis. If we compare the PFS in both trial, we can see that the separation of curve in Archer trial is late. We can see it around 6 months, whereas in osimertinib trial, the separation start from the beginning of the trial only. And of course, the median PFS benefit was better in Flora trial as compared to the Archer trial. Similarly, we can see that that trend with overall survival also. Moving on, as highlighted that osimertinib has better CNS penetration. This trial studied the effect of TKI in CNS metastasis, whereas dacometic trial specifically exclude patients with brain or leptomeningeal metastasis. Kaplan-Meier curve separated early in osimertinib trial, whereas separation occurred around 6 months in dacometinib trial. Although the response rate were more or less similar, median PFS was more with osimertinib, whereas median PFS was around 14.8 months with dacometinib. And dose reduction was more in dacometinib in 66% of the cases, whereas in osimertinib it was only in 3%. And serious adverse event rate was also higher in dacometinib, approximately 27%, whereas it was only 4% in osimertinib. Again, this is the same thing. So as we all know, the problem with first generation TKI was isolated CNS relapse. So with osimertinib, we see that the CNS response rates are higher, CNS failure rate is low, and that's why this is now the first line treatment for metastatic NSCLC with EGFR mutation. As preclinical studies have demonstrated that osimertinib has better CNS penetration as compared to other first and second generation TKIs. So Flora trial established the role of osimertinib in metastatic NSCLC in first line setting. Also, this trial included patients with CNS metastasis, and it showed benefit in both patients with CNS metastasis or without CNS metastasis. So we can see that patients with CNS metastasis tend to do worse as compared to patients without CNS metastasis. So if we compare the PFS, osimertinib showed PFS of 15.2 months versus 9.6 months in patients with non-CNS metastasis. Whereas without CNS metastasis, benefit was 19.1 months versus 10.9 months. So, CNS PFS was not reached in osimertinib, whereas 13.9 months in standard of care, although this was the subgroup analysis. And CNS progression rate in patients with non-CNS metastasis was 19 versus 43 months, whereas without CNS metastasis, it was 3 versus 7%. So, as already highlighted, that NCCN guideline endorse osimertinib being the first line agent in metastatic NSCLC with or without brain metastasis in EGFR mutated NSCLC. A brief about the tolerability of all these TKI. So osimertinib, the discontinuation rate is around 15% as compared to other TKI, it is 19%. And any grade 3 adverse event rate is 18% with osimertinib, whereas with other TKI, it is 29%. So majority of the side effects of EGFR TKI are diarrhea, rashes, skin changes, although AST, ALT elevation is less with osimertinib as compared to other TKIs. So already discussed in Archer trial, the discontinuation rates were higher with dacometinib whereas in osimertinib, discontinuation rate was only 4%, and dose reduction was higher with dacometinib as compared to osimertinib. So this is already discussed. We'll move on. And these, as expected, dacometinib was not that tolerable in geriatric population, and discontinuation rate and dose reduction rates are pretty high, particularly in geriatric population. So brief about, as we are in resource limited setting, so there is always a debate about the sequencing of use of TKIs. So although the recommended is osimertinib in first line setting, but in Indian context, this may not fit because the cost of course, the cost of osimertinib is pretty high, and we have generic formulations of first line TKIs. So how do we sequence them? So there was a geotag study which showed that if we use afatinib in first line and later on adding osimertinib after the progression on afatinib, the median OS was 41.3 months, which is pretty high as compared to the osimertinib trial, FLORA trial, which showed that median OS was 36 months. Although this was a retrospective data, this cannot be directly compared with a phase 3 randomized trial, which is FLORA trial for osimertinib, and we cannot solely based on this study endorse that we should use afatinib followed by osimertinib. So I think we cannot predict which patient who will progress on afatinib in future will have EGFR T790M mutation, as in second line setting, osimertinib is particularly approved for this mutation only. So we cannot predict that which patient will develop this mutation or which will not. So I think osimertinib should be the first line agent for EGFR mutated NSCLC. This is the brief algorithm. For commonly mutated with or without CNS metastasis, osimertinib is the first line management. For uncommon mutation like de novo T790, osimertinib, exon 20, these patients does not respond that well to osimertinib, and standard treatment is chemotherapy, or nowadays we have targeted agents for this mutation also. And other exon 18 to 21 mutation, afatinib is a better agent as compared to osimertinib. So in summary, osimertinib has demonstrated better overall survival, better CNS penetration, better CNS PFS as well as OS, and FLORA trial has definitely established it to be a first line agent irrespective of mutation. irrespective of metastasis site, age, ethnicity. So I think with that message, I would like to conclude my presentation. I would be happy to answer any questions. Thank you.
Thank you so much, Dr. Rakesh, for this wonderful presentation. So I had this small query. So what is your experience with the osimertinib as you have used in your patients? So what is the side effect profile that you observe with this?
As most common are the skin changes only. Skin changes, diarrhea, skin toxicity. These are the pretty common side effect with any EGFR TKI. So these are the only side effects that I have observed so far.
Yeah, so but we commonly feel that compared to erlotinib and geftinib since that we have been using since many years, osimertinib is relatively well tolerated.
As
What
compared to the TKI, better tolerance is with osimertinib.
in your practice, do you feel that approximately out of 100 patients, how many of them are able to take osimertinib? Like how many patients, and are you prescribing it to all patients in first?
I counsel all my patients about the benefit of osimertinib as compared to other TKIs. But of course, the cost of osimertinib is pretty high as we don't have any generic form of osimertinib. I think only 10% of my patients are able to afford osimertinib. Rest other are taking first generation TKI only.
Okay, so if there's any other question with Dr. Rakesh, with any of the from any of the audience, feel free to ask, please. Okay, so thank you, Dr. Rakesh, for this wonderful presentation. We learned that about the benefits of osimertinib and how it has progressed from this second line, third line space to the now the front line. And now with the ADAURA results, it has become important drug in the adjuvant setting as well. So hopefully with the advent of these newer implications, the survival of lung cancer patients is going to increase day by day without much toxicity. So
Thank you, Dr. Kapil, for providing me this opportunity. Thank you.
okay. So after this is Dr. Anshul Gupta. I think Dr. Anshul is still on the way. He's stuck in some traffic. So he will take somewhat more time to be online. So in the meantime, I think we can start with the panel discussion. So can I take the attendance of the panelists, Dr. Nitin SG? Dr. Nitin SG is online?
Yeah, I'm online. Hi, Kapil.
Okay. Hi, Nitin.
Hi,
Dr. Siddharth?
Yes, sir.
Okay. Dr. Sandeep? Dr. Sandeep? Dr. Aman? Dr. Aman? Okay. Dr. Raghavendra? Hi, Dr. Sandeep. Dr. Sandeep has come online. Dr. Siddharth is here. Dr. Nitin is here. Dr. Aman? Dr. Raghavendra? Can somebody please just call Dr. Raghavendra and Dr. Aman?
I'm trying
From the
connect with Dr. Raghav.
yeah, please. So I'll be sharing my slide.
हाँ तुझे just join this then.
Hello, yeah. So we have Dr. Siddharth, Dr. Sandeep, and Dr. Nitin. We are waiting for Dr. Aman and Dr. Raghavendra to join. Are my slides visible? Yeah, Dr. Aman.
Yeah, I have joined Dr. Kapil. Hi.
Yeah. Hello, Dr. Aman. Hello, Dr. Aman. Yeah. So I'm sure Dr. Raghav will join in a few moments. I will be going ahead with the panel discussion first. So here we will be discussing a case, which is a case of early stage lung cancer patients. Let me first introduce my esteemed panelists. So we have Dr. Aman Chaudhary. He's a DM Medical Oncology from AIMS New Delhi. We have Dr. Raghavendra, who is also DM Medical Oncology from AIMS New Delhi. We have Dr. Nitin SG, who is also doing DM Medical Oncology from AIMS New Delhi. We have Dr. Sandeep Tiwari, who is doing DRNB Medical Oncology from Action Cancer Hospital. And we have Dr. Siddharth Pant, who is also doing DRNB third year Medical Oncology from Action Cancer Hospital. So we'll be just discussing a short case on early stage lung cancer patient and how are the practices going on in your practice, how you are going to treat this patient. And then we will be followed by a brief discussion about how we can optimize the management of such patients. So starting with the case, so we have a 67-year-old gentleman who comes to your OPD in one fine day. Patient says that he's a non-smoker throughout his life, and he presented with mild cough. Chest X-ray, you got a chest X-ray done. It shows a small lesion in the left upper lobe. You order for a CT scan, and it shows a lesion in the left apical lobe. So you got a PET CT scan of the patient done, and this is the picture that comes. In the CT scan, you are able to see this lesion in the this lobe, and on the PET scan, you see this is a high avidity lesion in the left upper lobe. On the sagittal section and coronal section, you can see. So the report says like this, that it's an intensely FDG avid, well-defined lobulated soft tissue nodular lesion in apico-posterior segment of left upper lobe with adjacent pleural text. Features suggestive of primary neoplastic etiology. Let's consider the size to be 4 centimeter. And they are also able to see non-FDG avid subcentimetric prevascular lymph node, likely non-specific reactive nodes. There is no scan evidence of abnormal hypermetabolism to suggest distant metastasis anywhere in the body in this history. So my first question is with Dr. Aman. So what next, Dr. Aman? What next would you like to order for this patient?
So, Dr. Kapil, I would like to do the further staging workup for this patient. I would like to, we already have a PET scan. So I would like to get a PFT done for this patient. And I would also like to do the mediastinal staging for this patient, as the mass was, I guess it was central mass. And you said the size was 4 centimeters. So as the size was more than 3 centimeters, I would like to go for mediastinal staging either by EBUS or EUS and doing a TBN. And if that turns out to be positive, then we'll have to go for a multimodality treatment. And if that's negative, then only we can proceed with surgery only.
Okay. Dr. Nitin, before proceeding for staging, is there any else that you would like to do before proceeding to staging?
The baseline staging has been done, as well as the biopsy was planned, right? So after that, I would like to, what was the size of the tumor?
It's 4 centimeter tumor, and with adjacent pleural text, and there are subcentimetric prevascular lymph node, likely non-specific reactive.
Okay, considering it would be stage, I think it would be 1B. Yeah, so from 2 to 3, usually we go for imaging of the MRI brain as well, ideally MRI brain, but we can't totally depend upon the PET scan for staging. So I think I would consider an MRI staging, because a study which was conducted in our AIMS itself has shown that around 15 to 20% of patients there is upstaging with MRI brain post staging. So even though it is stage 2, I would definitely go for stage 1B. I would definitely go for an MRI brain.
So for this patient, you would like to go an MRI brain also, right?
Yeah.
Yeah. So Dr. Sandeep, what will you like to do in this case? Dr. Sandeep. Dr. Siddharth?
Yes, sir. So, in this case, this seems to be a centralized tumor with possibly a non-specific reactive nodes shown on the PET scan. So I will definitely go with the mediastinal staging also. And for if it's a stage 2 disease, so I will also go for a brain MRI. as well for staging workup.
Why do you call it a stage 2? Why do you call it a stage 2? It's a
So-
4 centimeter tumor, so it's a T2A.
Stage 1B, okay, sir. So it's a 4 centimeters will be stage 1B, sir. And for stage 1B, usually we don't do, but for stage 2 onwards, we usually do.
So in this patient, you will skip MRI, right?
In this case, for
Yeah.
one
Dr.
1B, sir.
Raghavendra, is he here? Dr. Sandeep? Okay, so back to you, Dr. Aman. What is your take upon MRI brain in this patient?
I would like to get an MRI done for this patient because, as
Mhm.
Dr. Nitin rightly pointed out, there was a study from our center in which we did a mandatory baseline CCT in all our NSCLC patients, and 21% of them were found to have asymptomatic brain mets, and that's a huge chunk. So
Yeah.
it's a usual practice at our institution that we do brain MR or a CT-MR, whichever is feasible, for all our patients. But as per NCCN, NCCN recommends from stage 2 and onwards. But I would like to do it.
Okay, right. So one panelist says that the MRI can be skipped in this, and 2 panelists are in agreement that the MRI should be done. So, so here we have the NCCN guidelines, which say for stage 1B, as we all agree, so this patient comes under stage 1B. So PFT bronchoscopy upon the brain MRI, it says that the brain MRI with contrast, it has to be done in stage 2 and stage 3A. For stage 1B, it's an optional recommendation. So you can do, you cannot, you can skip it as well. So it depends upon the symptoms of the patients. So the brain MRI has been done. It comes out to be negative. Then we try to obtain a biopsy. So what are the sampling technique that you would prefer? We start with Dr. Siddharth.
So first of all, it's a centralized tumor, so we'll go with the bronchoscopy, most likely to be a EBUS, and probably we'll try to get a biopsy in that procedure. Also, we'll doing EBUS TBNA. And for a tissue diagnosis, and also we will try to look at the since in the PET scan it was showing a reactive lymph node vascular, so we'll have to confirm it also, because if it's come out to be positive, then we have to go for the mediastinal staging with mediastinoscopy. So this has to be so while doing EBUS only, we'll do a tissue diagnosis, a lymph node sampling, and the further report.
So you will do it in the same setting. You will do the bronchoscopic biopsy as well, and you will take the sampling from the mediastinal node also. Dr. Nitin, do you agree, or you have anything else to add on?
I would definitely agree to what the earlier panelists told. I would like to go for a bronchoscopy, but I'm not sure whether sampling of that lymph node would be possible because it's prevascular. I think it would come as 3A, I guess. So 3A
No,
won't
of course,
be.
you don't. You take only FNAC. You don't go for biopsy from that.
Even
lymph
FNA won't be
node.
possible through EBUS, I guess, because it would be prevascular and won't be approachable through EBUS. So usually we.
Of course, subject to the
Yes.
subject to the technical expertise of the bronchoscopist, and moreover, whether it's possible or not. So that's a one step ahead, whether it's possible or not. But would you actually like to order?
Yeah,
the test or not?
definitely. We considering it is a central tumor, and definitely mediastinal staging has to be done. The ideal technique to do is mediastinoscopic biopsy or intraoperative biopsy. But yes, for a pre-op staging, we can do a mediastinal sampling along with bronchoscopy. And
so really, like, how many patients do you go for open mediastinoscopic or not open, but I mean mediastinoscopic mediastinal staging? Like how many
I would say it
patients
is
do you go for?
none in our institute, because most of these patients,
Exactly.
because of the logistic
Exactly.
issues. But ideal recommendation is mediastinoscopic sampling, which will give a better accessibility as well as more tissue for further analysis. But otherwise, and even through bronchoscopy, it all depends upon the expertise of the pulmonologist. But still, many of the lymph nodes might be missed, which we can actually sample during surgery.
I think even in the private setup where the logistics is not an issue, mediastinoscopy is not a simple procedure. So I think most of us are doing via bronchoscopic guidance only, and then it depends upon the the clinical suspicion also. If the imaging shows clearly it's non-reactive and bronchoscopy guided you try to do, and if it's not non-malignant, you can take it like that. But if the clinical suspicion says on the imaging it is suspicious of malignancy, and in the bronchoscopic you are not getting anything, then you may go ahead with the mediastinoscopy. But otherwise, it's a fairly complicated procedure. Dr. Aman.
Yeah, Dr. Kapil, about this, about the mediastinal staging, what ESMO says is that if you have a positive PET scan, like we had this positive FDG node in this patient, so in that case, we have to do initially mediastinal staging via EBUS or EUS guided TBNA. If that turns out to be negative, then that is to be considered as negative. If that turns out to be positive, then that is to be considered positive. But if that is negative,
Definitely.
if that is negative, then that is to be confirmed by a VATS or video assisted mediastinoscopy. So
Mediastinoscopy.
yeah, if that turns out to be negative, initially you have to do
And
TBNA.
suppose if the imaging says that, like in this case, the imaging mentioned clearly likely infective non-inflammatory subcentimetric. You get a bronchoscopy done, the lymph nodes either you are not able to sample, or even if you sample, they come out to be negative. Do you still further pursue mediastinoscopy or VATS, or you are comfortable with the negative report?
See, negative report of what? This TBNA.
Yeah, with the mediastinoscopy.
No, if that TBNA report is negative, then we have to confirm it by mediastinoscopy. If PET was positive, if the PET was negative,
if the PET scan is negative, I mean PET scan is not showing,
PET is negative,
and the bronchoscopically guided, either it was not feasible, or you could see only the blood clots in the sample, or it was negative. So then then I would consider confirm by mediastinoscopy, or you're comfortable
no mediastinoscopy in that case. I'll be comfortable with TBNA only.
Yeah. So I have another question, Dr. Aman. Suppose this patient had a supraclavicular lymph node as well, palpable. Do you still like to go ahead to take biopsy from the primary primary lung mass, or you're comfortable taking biopsy from the supraclav node?
No. Taking biopsy from any accessible site is the preferred mode. We can just totally excise the supraclav node, and we can get adequate tissue that will be more safer than the than sampling a central lung node. So that will be okay if we sample the supraclav node. That will be okay.
So usually what we do, if the patient, if otherwise technically and patient's morbidity profile wise, patient fitness wise, bronchoscopy or peripheral USG guided, CT guided biopsy is feasible, then we go with that. Only if the patient is very frail, central tumor, patient cannot undergo a bronchoscopy or any kind of sedation. Only in those cases we go for sampling from lymph node. If it's a liver metastasis, then definitely you can take biopsy from there. But lymph node might not give you positive, adequate result. That's what I believe.
Okay.
Any Dr. Nitin?
No, I disagree to that. I disagree to that. Any tissue would be sufficient. I mean, lymph node is also sufficient, even though guidelines say that liver lesion would be better and lymph node lesion would be less. But from our experience, what we see, this majority of lymph nodal biopsies were enough to do all the mutation analysis and the studies for the studies. So I think it won't be a problem, and it is easily accessible, and we can go for that itself.
Yeah, Doctor, as Devita says, we can do biopsy from any accessible tissue.
Dr.
Yeah, of course.
I think the term is to biopsy that lesion which will upstage the patient. So I think supraclavicular lymph node biopsy will definitely make it stage 4. That should be the ideal site for biopsy.
Okay, so but I mean, you want to say that the lymph node biopsy will be preferable in that, so as to upstage the tumor?
I mean to say that biopsy that lesion that will upstage the patient.
I agree. If it's a metastatic lesion, then you take sample from the metastatic site.
Yeah, so supraclavicular lymph node should be the ideal site because it will label the patient stage 4 and it will also establish the tissue diagnosis.
Okay, so the general consensus is that we will take biopsy from the lymph node. Fair enough. So moving ahead, Dr. Siddharth. Dr. Siddharth?
Dr. Raghav is also connected now.
Yeah. Oh, welcome, Dr. Raghavendra. Dr. Raghavendra? Dr. Raghavendra, please unmute. Okay. Dr. Siddharth, are you there?
Yes, sir.
Yeah. So what are the other lab tests you would like to do in this patient before you have done the biopsy, you have done the mediastinal staging? Is there anything else you would like to do for this patient?
So apart from this, the routine blood parameters of CBC, KFT, LFT, and and if the patient is having comorbidities, so we have to look for any lung function test also, and for any cardiac evaluation for with the 2D echo, and these all will be done apart from the biopsy.
Okay. And any other panelist?
Pulmonary function test has to be done at baseline if we are considering
Yeah,
for
so I think we'll go with the 2D echo and pulmonary function testing to assess for the resectability of the tumor. So patient underwent a pre-treatment evaluation. So would you recommend brain MRI CT scan at the baseline in early NSCLC? So I think we had a discussion about it. Yes. And in which group of patients? So from stage 1B, it's optional. From stage 2 onwards, it becomes a norm. So, but according to the AIMS study, which was quoted, so we start doing it from the 1B onward, that is more than 3 centimeter or 4 centimeter onward, we start doing MRI brain. So role of pathological or mediastinal staging in early lung cancer, we have already established that. And procedure commonly used for central and peripheral tumors. So usually we do it before surgery, during surgery or after surgery. I think we are all in consensus that we do it prior to surgery rather than doing intraoperatively, if at all the mediastinal lymph node were not accessible preoperatively, then we can do mediastinal staging at the time of surgery itself. So Dr. Nitin, do you feel that it's a challenge that getting an adequate tissue sample biopsy, you have to do IHC markers also, then nowadays you have to send the sample for a marker driver mutation studies also, you have to send a sample for NGS also, and tumors are sometimes, with the more advent of CT scan for other indications, you feel that many of the patients are now coming with small tumors of 2 centimeter size, 3 centimeter size, 4 centimeter size. So do you feel that getting adequate sample is a challenge in your practice, and you feel what else, what extra do you do to overcome that challenge? Dr. Nitin.
As you told, it's actually a difficult situation, especially in lung cancers where the primary tumor would be very small, and majority of metastatic site may not be accessible for biopsy. So in such cases, it is an issue to get a adequate sample. So what we follow usually is that whatever sample we get, we do minimum IHC markers, especially if you're thinking it is adenocarcinoma. We don't go for all the panel. Instead, we just go for TTF1 to establish adenocarcinoma, and P53, P63, P40 for squamous cell carcinoma, and majority of chunk of the tissue, if you think that is adenocarcinoma, is left for mutation analysis, because that has got a predictive significance in case of lung carcinoma.
Agreed. Dr. Siddharth? Is Dr. Siddharth here?
Yes, sir.
Yeah. So what do you feel in, suppose you biopsy 100 patients of early lung cancer. So what do you feel in what % of patient you find the tissue sampling desperately challenging and you're not able to get a sample? Like what %? Can you put a number?
I think I don't know, sir, about this percentage. Exact.
No. I'm not saying it's not a theoretical question. I'm asking it's a practical thing. Like, what do you feel?
So normally for early stage, definitely the percentage will be high for early stage disease. And that's why it is very important that if we are doing it during the surgery, then we have to have a frozen section at the time of surgery. So it's like in the NCCN, they have advice for the ROSE guidelines, rapid on-site evaluation. So that's why we have to attempt multiple times in order to get a good yield of the sample.
Dr. Sandeep Tiwari, are you online yet? Dr. Raghavendra, is you online yet?
Yes, I'm on.
Yeah, hi, Dr. Raghavendra. So what do you feel in your practice, in your clinic? You are sitting there and Dr. Prabhat Malik sir OPD, and a patient comes to you. So what do you feel? What % of patients are not able to have an adequate biopsy?
These days, actually, since we're doing core biopsies, we attempt to get maximum number of cores as possible, usually over 2 or 3, and we try to get as much tissue as possible. There is a difficulty. I would say probably in every 10, probably 2 patients or 3 patients might have some difficulty. But in most of the cases, we do end up getting adequate tissue by attempting at getting multiple cores, which should at least cover the basic IHC panel.
So you feel that 10 to 15% patient, you still have difficulty. So yes. Dr. Aman, what is your strategy in those patients?
See, Dr. Kapil, in those patients, if the patient's tissue is not accessible, or if the patient is too frail, we at our center usually prefer liquid biopsy for those patients. In liquid biopsy, although the
But
approved,
you see, we are talking about early lung cancer. Liquid biopsy is likely to be negative.
still if you don't have any tissue,
Yeah, we
any
do get
method of
a liquid biopsy. Yeah.
see, in that case also, if it is even early stage cancer, then the sensitivity of liquid biopsy is still 60 to 70%. You have,
Right.
if you don't have any means of doing the tissue biopsy, then liquid biopsy can help. Or if
And
the liquid biopsy
let's
is
say
still
liquid
negative,
biopsy.
then you can
Liquid
then
biopsy
again,
also comes negative.
then you can again try for a biopsy from the same lesion. You have no option left.
Right.
To add to it, actually, we also had patients who we did only FNAC. On cell block, we could actually do EGFR, ALK, and ROS. So it's not that in such cases where we are out of all the options, we can actually go for FNA cell block, and in that also we can.
Moreover, Dr. Nitin, I think just to make a diagnosis in the FNAC is enough. Yeah, anyway, we
Yeah,
are going
make
to
a
take
diagnosis
patient for the
FNAC.
surgery, then we can do on the surgery specimen, we can do plenty of tests. We can run later on.
Yeah, to just make a diagnosis, FNA cell block is enough to do IHC.
Yeah, to take up a patient for surgery, we just need to have a diagnosis of malignancy. We don't even need to know whether it's small. I mean, don't even need to know whether it's adeno or squamous, right?
I would agree with Dr. Kapil. Yes.
Yeah. Okay, so these are the NCCN guidelines about the pre-operative workup. So if this patient is stage 1A, that includes peripheral lesions of T1A, B, C up to 3 centimeter with no nodes, then we have to get a pulmonary function test PF done and a bronchoscopy. We prefer intraoperative. We can also do, because this is a peripheral lesion, so we feel that the chances of mediastinal node becoming positive is low. That's why we can skip operative and we can do simultaneously. And then we consider pathological mediastinal lymph node evaluation. We do a PET scan as well. So if the patient has negative mediastinal node and it's operable, we take up for the surgery. If they're medically inoperable, we take up for definitive radiotherapy. And if the patient is stage 1B onwards, which is a peripheral T2A N0 lesion, or stage 1 in which stage 1 like similar to above, but patient has a central lesion. In those cases, we have to do PFT, but here the bronchoscopy is done pre-operatively rather than the intraoperatively. For a stage 1A lesion, if the tumor is peripheral, then you can go for intraoperative bronchoscopy. But if the patient is patient has a central lesion, then we have to do bronchoscopy pre-operatively and pathological mediastinal node evaluation. We also go for FDG PET and MRI brain has to be done. Stage 1B optional, stage 2 onward, it is to be done. So in this patient, we got an endoscopic ultrasound done and we did not find any enlarged mediastinal nodes. So patient was medically fit, operable. He underwent good surgery. And this is the post-surgery report that you see. So there was a single tumor, which was invasive adenocarcinoma, moderately differentiated. So there was visceral pleural invasion, which makes it a T2. And lymphovascular invasion was not identified. All the margins were negative. And the regional lymph nodes were 2 lymph nodes had metastatic deposits. So the pathological stage become T2 and 1, which is a stage 2 tumor. So, Dr. Nitin, back to you. Do you check for any molecular biomarkers in early lung cancer? You just treat them like that?
Yes, with the advent of ADAURA trial, where EGFR mutated lung cancers, we have an option of giving adjuvant osimertinib. So after the advent of that, we have started doing biomarker testing for all the patients. Even otherwise also, we usually do biomarker testing, which would be helpful for us in future when the disease recurs or when the disease is progressing, not responding to therapy. But yeah, we do biomarker testing in general for all patients whose biopsy are being done.
So, Dr. Aman, what kind of panel are you sending in these patients? So, are you comfortable ordering just EGFR Alcross, or you are getting a comprehensive genomic panel, or you are getting a lung panel like 1215 gene? What is your strategy?
No, Dr. Kapil, as we have a very poor profile patients at our setup. So
no, let's say patients is not poor. They have all the money in the world.
For early stage cancer, I'll be interested only in EGFR and PD-L1. But as Dr. Nitin rightly said, ki ADAURA trial has shown DFS advantage in the patient who were EGFR mutated. And also for PD-L1, we have options for, if the driver status is negative, then we can have options of atezolizumab from IM power 010, and if the PD-L1 is more than 1%, and irrespective of PD-L1 status, we can give pembrolizumab
So
based on
you
keynote
don't want
091.
you don't want to check for ALK and ROS mutations?
No, not for early stage lung cancer.
Okay, Dr. Raghav,
Yes,
what's your opinion?
I would like to differ a little bit. I would definitely consider biomarker testing even in early lung cancer because there are some upcoming trials and where not just EGFR, but people have used adjuvant ALK inhibitors. The data is yet to be awaited. And taking a step further, the importance of biomarker testing in early lung cancer is improving because there is a trial called the LEADER trial, which is now going on, which is ongoing. It's a multi-center trial across the Atlantic, both Europe and USA, where all patients who have been taken under the trial, they have been tested for the 12 to 15 biomarkers, including BRAF, including NTRK, and all of this biomarker testing is being done with one purpose being to identify the percentage of these kind of driver mutations in early lung cancer and also to target them. Patients are now receiving both neoadjuvant and also adjuvant strategies based on this biomarker testing. It is an up and coming thing, and pretty sure as the results of ADAURA have shown, there could be a very significant overall survival benefit, and also by using this in adjuvant strategies, and also a chance of even achieving a PCR by using neoadjuvant. Both strategies are being evaluated.
Exactly.
Dr. Siddharth. Yeah, Dr. Anshul is here. Hello, sir.
Yeah, hi. Thank you, and apologies for stepping in late. So I'd like to add
No
a point, just to what Dr. Raghav said. See, of course, all these trials are there, upcoming trials, which would perhaps, in the near future, change the definition of how we view adjuvant lung cancer treatment in mutation or biomarker positive lung cancer. Another thing is, see, if any of these are positive, then they kind of preclude response to immunotherapy, which is again,
Exactly, right.
we are now increasingly using. So that is another thing to bear in mind before excluding these in our work.
Yeah, exactly. Very well said, Dr. Anshul. So this is in my practice how I do. It's somewhat in between approach between what Dr. Aman and Dr. Nitin said and between what Dr. Raghav said. So typically, I am ordering a specific marker, just 10 or 12 gene panel plus a PDL1. So now we have started using neoadjuvant and adjuvant setting immunotherapy. So recently this Keynote 671 trial, it was presented in ASCO 2023 meeting, which has shown a DFS benefit of using perioperative pembrolizumab. So in those, although in this trial they had taken EGFR positive, ALK positive patients also, but usually if the patient has any driver mutation, be it EGFR, be it ALK, be it ROS, then the immunotherapy should not be used. Furthermore, the Keynote 816 trial, in which the neoadjuvant nivolumab was used, those patients were excluded. So it excluded the EGFR positive patient and it excluded the ALK mutated patients also. Starting from clinically T4 lesion, more than 4 centimeter lesions, stage 1B onwards. Now, I think sooner or later, even now, we are about to start with the neoadjuvant immunotherapy. So in that setting, the markers become important. And with the PDL1 also, if the expression is more than 1% versus less than 1%, there is significant difference in the response rates. In the EFS benefit is there in the PDL1 more than 1%, while it's not there in the PDL1 less than 1%. So that is my approach. So that's how we do it. So if this is done, so pre-surgery tissue or the post-surgery tissue, I think it's post-surgery, we have a larger tissue. So I think post-surgery, we like to do that. And which biomarker do you check for EGFR, ALK, PDL1 or any other? So I think we had discussion while there is lots of discordance. So Dr. Aman, back to you. So do all patients with early lung cancer, which includes stage 1 to stage 3A, do they undergo surgery? What do you feel?
See, Dr. Kapil, the early stage lung cancer, the tumor which are considered as borderline resectable are those with the T3 tumor and a broad base of contact with pleura, like more than 5 centimeter. T4 with N0, N1 is a relative borderline resectable tumor. And N2, which is multi-station and bulky N2, that is considered as again a relative contraindication to surgery.
Unresectable, right? Yeah.
Yeah.
So what percent do you feel if technically just forget about the staging, if technically they are resectable, so even after that many patients are inoperable. So I'm talking about the patients who are technically resectable. So what percent of those patients actually undergo surgery?
Can you please repeat the question?
So there's a thing called as inoperability. There's a thing called as resectability. So technically the tumor is resectable, like tumor is does not have any bulky N2 lesion or is not invading the pleura and all those things. Like it is resectable. Even if it is invading pleura, that is also not a unresectability criteria. So, but then there may be patients who are inoperable due to the COPD or the comorbidity or the ECOG performance status poor. So those patients who are actually resectable otherwise by imaging, but who are actually able to undergo surgery. Yeah, exactly. So
I don't have the exact answer, but maybe if I have to say a number, then maybe 20 to 25% are unable to undergo surgery.
20 or 25% patients are unable to undergo. So you are saying at your center 70 to 75% patients undergo surgery.
Yeah, because most of them are usually chronic smokers. They have poor lung reserves. So maybe.
Let's take the question to
take
Dr.
into
Nitin.
consideration that they don't progress, while waiting for the surgery.
So, Dr. Nitin, taking you to this question. So, what percentage don't undergo resection, even though while technically resectable? What do you feel?
I think majority doesn't undergo resection. I mean, I would say at least more than 50, around 55-60% undergo resection in early stage, because logistic issues are too much that in the waiting period itself, most of the patients progress by the time the surgery is being done in our institute. That's what I'm telling. And the chunk is too much.
Dr. Aman and Dr. Nitin both working in AIIMS. So Dr. Nitin unit does operate 75% of the patient. Dr.
I would say around 40% undergo surgery. That's all, not more than that. That's what I experience from my experience.
But that is due. But that is due to
Dr. Siddharth.
So I would feel that looking at
what is happening in action, what is happening in action, like how many patients here you do not have a in action where you are practicing, you do not have a logistic constraint. You are able to provide early data.
Action, we don't have any thoracic surgeon here. So usually we don't see any patients of early stage disease to go for upfront surgery. But overall,
please don't say that. I got a patient resected in action. Dr. Rajesh Chen does a very good surgery. Don't say that in action we don't have pneumonectomy going on.
So across the board, but if you look at the trials for stage 1 to stage 3, the broad ballpark figure is around 40 to 50% undergo surgery, and this increases to 70% for stage 1 disease, and it becomes to 10 to 15% for stage 3 patients. In the even in the and if the patient is undergoing a neoadjuvant treatment in the checkmate also, 25 patients were not able to undergo surgery after chemotherapy in both arms.
Okay, so Dr. Raghavendra, what do you feel apart from the logistics, apart from the comorbidity, about the smoking? Is there anything particular that you want to highlight?
Actually,
other regions?
I would exactly like to add that if you see a proportion of patients, we do see a significant proportion of patients who are called as medically inoperable because either because of comorbidity or age or performance status not being on their side. So this is actually a problem that is pretty common these days, and in patients who are older than 70 or 75 with this comorbidities, and most patients having a adenocarcinoma on biopsy, we see these patients. I would say if you see 10 elderly patients of over 70, if you see, then definitely about 3 to 4 would definitely be not in a position where they can undergo surgery, and such patients have actually got I would say a boon with the fact that by using stereotactic brachyradiotherapy, these patients are now being offered a curative option. And I myself have seen a couple of patients where sitting in the screening OPD, I've seen patients about 75, 80 years of age, adenocarcinomas, like 3 to 4 centimeter, but having bad performance status. So these patients, I remember referring for stereotactic brachyradiotherapy in a private setup, and I hope they have gotten that. And there is data also showing along with SABR, they're using ICI checkpoint inhibitors, with good results and good survival. So that is definitely a good option in such cases. I definitely have come across 2-3 patients in whom I had referred for SABR since they were medically inoperable.
Okay, fair enough. So, the patient underwent surgery, as you have seen the report, is PT2N1 lesion. So now we are contemplating about the adjuvant therapy. So, Dr. Nitin, so early stage resected NSCLC, what are typically the patients that you are referring for radiotherapy?
We usually send those patients, I mean, stage 1, any patient who's having a margin positivity on after surgery, we have to go for adjuvant radiotherapy. Other than that, adjuvant radiotherapy usually we give adjuvant radiotherapy doesn't have any role, to be frank, other than those patients who are margin positive. Usually we don't consider adjuvant radiotherapy.
Apart from the margin, so you are sending the patients who are margin positive. Apart
Yeah.
from that, any other subset of patients?
Maybe bulky in N2 if comes, I mean, if the after surgery turns out to be N2 and it was not completely resected, also we can go for radiotherapy. But in general, we don't.
So
usually
incompletely resected is as good as margin positive. Incompletely
Yeah.
resected is as good as margin positive. That
Yes,
is clear indication. So any particular stage like stage 2, pleural tag involved, anything like that? Any
No,
other
nothing.
indication? Nothing. Dr. Siddharth, would you like to add?
Yes, so the role of radiotherapy in adjuvant setting is very limited nowadays, especially after the port meta-analysis, which was done specifically for the early stage disease. And in the ANITA trial also, it was only shown that the response of RT was seen in only in N2 patients. But that evidence was also assessed in the lung art analysis, which showed that
Right.
even though the response was 50% decrease in the local recurrence, but that was offset by the toxicity which was occurring with the radiotherapy. So as of now, apart from margin positivity, even patients have now not been recommended for N2 disease simply because of the toxicity.
Right. So, Dr. Aman, I'll coming back to you. So, what is the role of stereotactic radiotherapy in early NSCLC? So, what I like to ask you, as Dr. Raghav had already nicely explained. So, do you follow any particular criteria up to this size of tumor? I will refer to SBRT. Up after this, I will not. Like, do you have any criteria or certain
Up to 5 centimeter.
group of
More
patient?
than 5, we usually don't take a patient for SBRT. Up to 5 centimeter, we do take patient for SBRT.
So up to 5 centimeter, you are taking patient for SBRT. So what are the usual group of patient that you refer for SBRT?
See, as Dr. Raghav has already explained about it, we usually take those patients who are medically inoperable, like due to poor comorbidities, older age, the poor lung function, who have FEV1 less than 1 liter. Those patients we usually, those patients who are unlikely to tolerate surgery,
so
those patients we refer.
Let me put it this way. Suppose the patient has a peripheral lesion, which is 3 centimeter in size. Apart from that, he has ipsilateral hilar lymph node also. So this patient is medically inoperable. So what about this patient?
Peripheral, what was the size of that tumor you said?
3 centimeter peripheral. 3 centimeter peripheral. Apart from that, he also has N1 lymph node. The hilar lymph nodes are also there. Medically inoperable. What's your strategy going to be?
SBRT.
SBRT? Hello?
Hello. Yeah.
Yeah. So SBRT. So you would like to give one SBRT focus on the tumor and another on the node, or what? Dr. Nitin.
Yeah, hello. Yeah.
Yeah.
Hilar node is also there. Yeah. SBRT can be tried. I mean, I'm not sure, to be frank. Hilar node, whether it can be covered within. I mean, we don't give SBRT to hilar nodes as such.
Exactly. Dr. Raghav?
Yeah, the chance of a peripheral lesion, with that, like you explained, 2-3 centimeters, the chance that the hilar lymph node would actually be positive would be below 20%. So
no, let's say the PET scan is very much suggestive of it's positive. Take it
or
positive.
suppose we have done a EBUS and then the node is positive.
If we did a EBUS, it found to be positive. It's a 2 centimeter node. It's a 2 centimeter node speculated like that typical node. Yeah, positive. Take it as positive.
Positive, pathologically. In that case, I would still consider SBRT to the primary lesion. And to deal with the node, since actually I do not have much data on how much immunotherapy would help, because it is still a trial kind of a situation where patients with such, especially patients with this kind of a presentation, they are receiving neoadjuvant chemotherapy just like in those, like in the format of Checkmate 816 or AGN, and they're receiving SBRT along to the primary lesion. So, but this is still in a
So
trial
you want
phase.
to apply a
Will it be applicable? I do not know. That
therapy,
would be
want to
theoretical
downsize it and then consider for SBRT. That's what.
Yeah.
But see, Dr. Raghav,
No,
even if
no,
the
no, no, no,
nodes
not for,
disappear
not for the,
after.
not for the primary. No, no, no. I'm not talking about the primary. People, this is a trial which is going on in which SBRT is given after a neoadjuvant immunotherapy, 2 to 3 cycles, and then that way you can deal with some systemic disease that is there, and you give SBRT to the primary lesion. But this is all trial basis. As far as we do not have any data
So suppose
regarding
the
that.
patient comes to you tomorrow, the trial data is not out yet. Patient comes to you on an OPD tomorrow. It can happen any day. Patient comes to you tomorrow. What advice are you going to give?
I would still prefer SBRT, but I would still confused about how to deal with the node. Can the node somehow receive some form of radiation apart from the SBRT field? I'm not sure. Probably a radiation oncologist.
Dr. Anshul, Anshul sir, how are you dealing? Dr. Anshul, are you there? So usually what I feel, I'll take this case in the multidisciplinary tumor board. So usually, as far as I know, we don't consider the hilar node. We have to address the node as well as we have to address the peripheral lesion also. And since the disease has spread from the lesion to the node, so we cannot just take it like that. We just address the primary, 2 separate primaries, and then we are done. So I think for this patient, I will take up for the radical RT, like typical concurrent CCRT that we say, but skip the chemotherapy if the patient, depending upon the patient performance status. So I think such patients should be taken for this radical RT rather than SBRT. That's what my approach is.
But to defer to you, what I would say is it's a peripheral tumor. So I'm not sure whether the single RT field, the peripheral tumor as well as the hilar node could be included. If it is being included, large area of lung would also be exposed. So it all depends upon patients. You already told that he's medically inoperable.
In radical RT, everything is.
No, radical RT we usually give. Mediastinal nodes are included in the radical RT if it is more of a central tumors. Extremely peripheral tumor, small tumor, we won't be able to include both peripheral tumor as well as the mediastinal nodes in the same portal.
No, Dr. Nitin. Suppose this patient had patient had peripheral 5 centimeter tumor, bulky N2 disease. What would be choice in that? CCRT only, no?
CCRT only, yes, but that's what I'm telling you. If you're the large area of lung would be exposed to RT, and you are telling the patient is medically inoperable. So it all depends upon patient, how fit is the patient. Because already the pulmonary function test is
that's
bad.
Where the role of tumor board comes in. That's why I'm talking about skipping the chemotherapy and give only radiotherapy.
And I would agree with Dr. Kapil, Nitin, in today's time, the radiation techniques are very, very advanced. So there's a difference between what we practice in AIIMS and, what is the situation outside. Even if the tumor is very proximal to heart, now they can, still do a lot of things with and reduce the GTV and, okay. So in today's time, we can do that technically. Agreed on your part that it may be difficult if the patient has poor performance status. And yes, I would agree with Dr. Kapil's strategy here. We may omit chemotherapy in this particular patient. Obviously the results may not be as robust, but then that is what we can probably give in this patient.
Exactly.
Okay.
So moving ahead, Dr. Siddharth, are you using any neoadjuvant therapy in early NSCLC cases?
Yes, sir. As per the data from the Checkmate, sir, we are giving using nivolumab in the neoadjuvant setting, primarily for patients with stage 2A and 3B and 3A, and also for stage 1B also. So based on the results, we are giving these patients.
So I beg to differ about that. So actually what happened in Checkmate 816 trial was at that time, the 7th edition of staging was going on. So what they took was actually tumor larger than 4 centimeter after the 8th stage. So at that time that used to be stage 1B, but now stage 1B is 3 to 4 centimeters. So now if you're talking about the current staging, that it should be stage 2 onwards. So you are using neoadjuvant immunotherapy. So any role of neoadjuvant chemotherapy in any particular subset of the patient, you are using neoadjuvant chemotherapy.
So so you said about chemotherapy in neoadjuvant setting, sir.
Yeah.
Yes, sir. So along with, so when we are using nivolumab, we are giving chemotherapy also with nivolumab, basically cisplatin doublet with cisplatin and based chemotherapy with nivolumab only. Approximately 3 cycles we are giving, and then assessing for the response assessment for surgical evaluation.
Okay. So Dr. Aman, the same strategy or anything else you are doing at AIIMS?
There is no definite role of induction chemotherapy for this non-small cell lung cancer. Only chemotherapy. It can just be used to just tide over the waiting period, long waiting period of the patient. It has not shown any benefit.
Forget about the waiting period. You are working in, let's say you are working in a very good MD Anderson Institute, USA, and a patient comes to you and he has got all the money. We are talking about the ideal situation. So
Neo plus chemo,
plus
past year
immuno.
where 24% versus 3%. So definitely Neo plus chemo, platinum doublet plus.
Okay, Dr. Nitin, anything to add or anything to skip? Anything to differ?
No, same. We do have few patients in AIIMS also who we were giving neoadjuvant therapy, and we have actually used low dose nivolumab, which also have found to have very good response. And all the 3 patients had CR at the end of neoadjuvant therapy.
Nice. Dr. Raghav, your favorite is also nivolumab, or are you convinced that the pembrolizumab also?
I think the question which you were trying to ask was what is the role of neoadjuvant chemotherapy, if any, in early stage lung cancer?
So I'm trying to ask both the question. Yeah, please.
Achha, both the questions. Okay. So addressing the first part of the question, yes. If you see that this benefit from receiving a neoadjuvant chemotherapy or adjuvant chemotherapy still remains the same. It's a 5% survival benefit that is there. So there is no benefit as much as giving NACT when compared to adjuvant. But there is one situation in which this induction chemotherapy can be used, such as an N2 disease, single station, non-bulky, to make it more operable, or easy to perform surgery. That is one situation, or the only situation where I would consider any form of neoadjuvant chemo.
There's another one, Pancoast tumors also. We are preferring.
Yeah, Pancoast, definitely. Yes, you're right. Pancoast is one place where definitely neoadjuvant treatment makes a difference. Coming to the second part of the question, yes, neoadjuvant chemotherapy along with immunotherapy, definitely, as the data that Checkmate 816 shows, or even the perioperative immunotherapy with durvalumab in AGN trial, or with neoadjuvant pembrolizumab, they have shown excellent results when it comes to the outcomes. So I would definitely include some form of immunotherapy in the neoadjuvant situation if it is feasible. And
so Dr. Nitin, talking about those patients you are giving nivolumab, what is your plan for the adjuvant? Are you going to continue nivolumab in the adjuvant setting, or you want to discontinue that? And what are you going to do about the chemotherapy?
There is no data of actually perioperative immunotherapy as such. I mean, nivolumab as such, yet there is no mature data.
There is. Exactly, there is.
For nivolumab, there is no data available right now.
For nivolumab, yes. Now we have perioperative pembrolizumab coming up big time.
Pembrolizumab coming up, but the data is not mature as much as I know. Atezolizumab adjuvant has been there, as well as pembrolizumab adjuvant has been there, but perioperative, the mature data is not yet, data is not mature to do that in our clinical practice.
So Keynote 671 trial, so which is there, which was presented in ESCO just last week. So it showed a perioperative pembrolizumab in which they gave 4, the criteria was same, more than 4 centimeter any nodal disease. So they gave 4 cycles of pembrolizumab along with cisplatin-based chemotherapy for 4 cycles preoperatively. Patient undergoes resection and they receives 13 more cycles, so to make it 1 year of immunotherapy. So they have seen the pathological CR rates are as good as the nivolumab one, from 4% to 24%, and they have shown that the event-free survival has also increased. Although the OS data is not mature, so is the case with the nivolumab trial also. So, but the basis of improved EFS, we can consider giving perioperative pembrolizumab. Although, of course, individual choice, you can give neoadjuvant nivolumab, you can opt for perioperative pembrolizumab. But if you have used,
Go ahead. Finish your statement, sir.
Yeah, so my point was, but if you have used a neoadjuvant nivolumab, then you should not use adjuvant nivolumab because we don't have any data about adjuvant nivolumab.
Just one point is that there is a, if you do a cross trial comparison, which is strictly,
we don't and it should not be done.
Yeah, but if you see the data of AGN, where perioperative chemoimmunotherapy was used with durvalumab and CheckMate 816, you see that at 3 years, the data which has been presented, I think a couple of months ago, and one was last month, you see that the 3-year disease-free survivals with CheckMate 816, only 3 cycles of a neoadjuvant immunotherapy along with chemo, and perioperative, which is neoadjuvant surgery followed by adjuvant durvalumab, which you see the 3-year DFS is still the same. It is very similar. It's like 63 versus 62%, this kind of a picture. So unless worse data matures, I would say that 3 cycles of nivolumab plus chemotherapy
It's
is
actually
also a
4.
very
It's
good.
not 3. Just to rectify, it's 4 cycle, not 3.
Yeah, 4 cycles. Sorry.
4 cycles. Yeah.
So I
So,
am
so
of the same view, boss. That see, even in the breast trial in which we give neoadjuvant pembrolizumab followed by adjuvant, okay, we are compelled to give that because it is a trial design and we have to follow that if we want to
Right.
replicate. And then the data of DFS, EFS is fairly close. PCR specifically is fairly close. Okay.
yeah.
So I would, rather refrain from giving my patient additional adjuvant pembrolizumab, which has always been the point of discussion in the breast trial as well. That what is the actual
Right.
worth of adding
Right.
adjuvant?
Because nobody knows. Nobody knows what's the optimum duration of adjuvant therapy.
Yeah, there is a proposed mechanism. I'm not sure how much it is true. They say that the lymphatics post-surgery is pretty much changed, and also there is no particular tumor that is left. So how much adjuvant would add to it is pretty debatable, but unless data is there, we cannot.
Agreed. Food for thought. I think food for thought
more
for
like
all of us.
Yeah.
Okay, perfect. So I think the consensus is about either neoadjuvant. Hello. Yeah, so I feel the consensus is to give neoadjuvant therapy only with nivolumab or pembrolizumab or durvalumab with a questionable benefit of adjuvant therapy. So in this patient, it's a stage 2 adenocarcinoma. Post-surgery, on the surgical specimen, you do a molecular testing. It comes out to be EGFR mutation, L858R mutation positive. So role of adjuvant chemotherapy in this patient, Dr. Aman, I would like to start with you.
Yeah, Dr. Kapil, I would like to give 4 cycles of adjuvant platinum doublet to this patient.
Okay, so what doublet?
Cisplatin plus gemcitabine.
Cisplatin plus gemcitabine is the same you are following, Dr. Nitin?
No, we follow pemetrexed, sorry. Most commonly.
Yes, Dr. Nitin?
Yeah, what we follow is pemetrexed plus cisplatin, even though the LACE meta-analysis showed that cisplatin plus vinorelbine has got the maximum response. But all over the world, I don't think anybody follows that because of the toxicity.
We're doing pemetrexed only. I think it's that's what I have been following. I was following that in action. Now in Rajiv Gandhi also, I am also following the same. Dr. Anshul, are you also following the same?
You're using cisplatin plus vinorelbine?
No. The pemetrexed.
Pemetrexed, yeah. Pemetrexed cisplatin, that's what we also follow 4 cycles following.
Yeah. Dr. Nitin, cisplatin or carboplatin?
Cisplatin.
Cisplatin, right. Dr. Anshul, are you also following the same, or do you have anything else to say?
4 cycles, basically. Although 4 to 6 cycles can be given if the response is there. Okay. And rather 4 cycles is enough, and cisplatin pemetrexed standard.
Sir, we are talking adjuvant setting. We don't see response here. We are talking
Yeah. So 4 cycles.
Yeah, 4 cycles. So this cisplatin pemetrexed only, right?
Yeah, absolutely.
Yeah. So Dr. Raghavendra, so you also, because patient is EGFR positive, you also think of giving osimertinib. Patient is affording. So do you start it with chemotherapy, or you forget chemotherapy, you give only osimertinib, or you start osimertinib with chemotherapy? What is your approach?
I think I would prefer finishing the adjuvant chemotherapy and then start osimertinib. I think that would be an approach I would take.
Dr. Siddharth, do you have any experience with adjuvant osimertinib in adjuvant setting?
Yes, sir. In our hospital, patients who are EGFR positive, patients with stage 2 to stage 3A, we offer osimertinib after completion of the chemotherapy. And in some patients also in stage 1B, we also offer, because even though the ADOR trial was done when the AGCC 7th was there, but they have shown then that's why that patients with a tumor size of more than 3 centimeters, in those patients we also can give osimertinib.
Okay, adjuvant chemotherapy, what is your regime of choice?
So for adenocarcinoma, definitely pemetrexed containing cisplatin pemetrexed, or in some patient carboplatin also.
Okay, perfect. So, what is the benefit of adjuvant chemotherapy and what is the drug regime? We have already touched upon this. So here we have a LACE meta-analysis in which we evaluated 5 randomized trial, BLT, ALPI, IALT, JBR, and ANITA trial. So it's a pooled individual patient data of 4,585 patients, out of which approximately 1/3 were stage 1, stage 2, and stage 3. And we see that 5-year OS benefit for overall 5.4%. So I feel that with the hazard ratio of 0.89, it's not that it's massively good, but it's still worth considering, especially if the patient is fit, young, and the toxicity is not much of a concern. But it is not magical response that we have to give it in whatever case. So the adjuvant chemotherapy benefit is still questionable. And as it is expected that in stage 1B, 2, and 3, it's expected that the benefit of chemotherapy in stage 3 is much more compared to stage 2, which is very minimal in stage 1B. So basically in patient with stage 1B, I usually avoid chemotherapy. In stage 2 and stage 3, we can give. So here we have already discussed the ADAURA trial. So it was presented recently in the ESCO meeting, the OS data. Initially, it was published in NEJM in 2020. So here we took the patients of resected adenocarcinoma lung, stage 2 to stage 3B, and we took them 3 years after the finishing adjuvant. Sorry.
Hello.
So we after the adjuvant finishing chemotherapy, we gave the patient 3 years of osimertinib 80 mg per day. In the other arm, we gave placebo. So both the arms were, as you can see, about the sex, the age, the smoking status, the ratio, the race. They were balanced. The AGCC staging at the diagnosis, if you see, both the arms had roughly 1/3 patient in stage 1B, 2, and 3A. Histology was adenocarcinoma, although a few were squamous also. The EGFR mutation was either exon 19 deletion or L858R mutation. So 60% of the patient in both arms had received adjuvant chemotherapy and 40% had not received any chemotherapy only. So if you see that the DFS, if you see that the hazard ratio is 0.17, which is absolutely marvelous. And you can see the curves also separating very early on, and the gap is maintained even with the longer follow-up. If you see the including all patients of all stages, the hazard ratio drops to 0.20, is still absolutely significant. And recently we had the ADAURA trial OS data presentation in ESCO meeting last week, in which they had said in the OS improved with the hazard ratio of 0.49, which is very, very significant. So giving osimertinib for 3 years improved DFS as well as OS, and we absolutely cannot ignore these data. And osimertinib is now the new standard of care for adjuvant therapy in EGFR mutated resected CA lung. Although there was a criticism of the trial because in the control arm, on progression, only 32% of the patients received osimertinib. Ideally, all patients in control arm should have received osimertinib upon progression or relapse, while only 23% received that. So basically, the control arm received inferior treatment. So that is one criticism. Nevertheless, the data are impressive, and I feel that osimertinib is now new standard of care for the adjuvant treatment in such population. So we have previously the RADIANT trial and CTONG trial, in which the geftinib and erlotinib were tried, and they were compared with placebo in the similar patient population of stage 2 and 3A in adjuvant setting. So we see in the erlotinib trial, there was some initial benefit, but then the curves seem to merge in the later part. And in the CTONG trial, we see that there was no overall survival benefit by using geftinib, and there were initial benefit with geftinib in the DFS curve, but later on that also seemed to merge. While in the ADAURA trial, we see that the curves are nicely separated with the hazard ratio of 0.17. This is an older slide where the OS data is not given, but actually the OS is also mature now, and median OS has not reached. 5-year OS is 85% in the osimertinib arm versus 74% in the control arm, and the hazard ratio is 0.49, which is statistically significant. So what are the recurrence pattern in patient with early NSCLC. So we see that the 11% of patient in the osimertinib arm had DFS event compared to 46% of the patient who had event in the placebo arm. And we see that the osimertinib patients, majority of the patient had local or regional recurrence only, while only 38% of the patient had metastatic recurrence. Compared to the placebo arm, most of the patient had metastatic recurrences. So what osimertinib is doing is taking care of the metastatic spread. It's taking care of distant metastasis, which is more important in the long-term survival. So CNS is also a common side of distant recurrence among patients with EGFR positive NSCLC. So in the adjuvant radiant study, 30 is which gave adjuvant erlotinib, 37% of the recurrences took place in the CNS, while in the osimertinib trial, if you see, only 1% patient had CNS disease recurrence, while in the 10% patient in the placebo arm, they had CNS recurrence. So specifically, osimertinib is preventing distant recurrences, more so very effective in preventing CNS relapses. So is ADAURA practice changing now that we have updated result available? Dr. Raghavendra, what is your opinion?
Yes, definitely ADAURA is practice changing. The concept of trying an adjuvant TKI in EGFR positive is not new. Since actually trials with gefitinib and erlotinib have also been done. While there was DFS benefit, they could never get that all-clinching OS benefit, which now with ADAURA we can show that with osimertinib there is definitely a overall survival benefit, which is the holy grail to accept therapy in oncology. And a justification which we can do how osimertinib has performed better than gefitinib or erlotinib is that osimertinib itself is a superior molecule. It causes covalent binding and irreversible inhibition. So there is definitely a physiological and a pathological basis for the results that we are seeing, and I think it cannot be ignored. So definitely I would say that it is a practice changing trial.
Agreed. Dr. Siddharth, what is your take?
So definitely it's the practice changing trials. Only my issue is that in the protocol says the osimertinib has to win for 3 years. So in an Indian setting, is it really feasible? Because the data says that the median number of drug exposure was 22 months, so close to 2 years. So patient took medicine for 2 years, but the trial says, but the recommendation for 3 years. So in the Indian setting, I don't know how much it is feasible to go for 3 years because it's also very costly and with some toxicity as well. So
see, Dr. Siddharth, the reason of duration being only 2 years was not the cost. It was under trial. So patients are getting the drugs free. The reason for median duration of osimertinib being 2 years was actually the disease progression or relapse or the event happening, right?
Yes, sir.
Yeah. So once the price comes down as the patent expires, so probably AstraZeneca takes some better patient access program, I feel that we'll be able to give osimertinib for 3 years.
I think another point is, Dr. Siddharth, in this situation, that see, when we deal with these EGFR TKIs or perhaps drugs such as even immunotherapy, what we need to understand is that even if we are able to cut short the time period of the recommended schedule or duration, we do achieve a significant amount of benefit. The dose response curve in terms of the duration is not linear. We do derive a significant amount of benefit upfront in the first few months itself.
Right. Yes. Perfectly said. Dr. Aman, your take.
Yeah, Dr. Kapil, ADAURA is definitely practice changing, and I would like to give osimertinib as an adjuvant therapy in early stage lung cancer.
Okay, Dr. Nitin, suppose patient is not affordable, as you're typically practicing in AIIMS OPD, patient says I cannot take osimertinib for 3 years. So would you just stop giving any medicine? Would you consider for some gefitinib or erlotinib or something like that?
No, nothing. ADAURA is very well impressive and would definitely like to get osimertinib if it is accessible. Then we'll go on with that. If not, nothing. We'll just observe the patient.
Okay, perfectly said. Is there any other difference of opinion? So here we have the NCCN guideline for NSCLC, in which we see that the adjuvant osimertinib is now a category 1 recommendation starting from stage 1B onwards. So it's a category 1 recommendation in stage 2B onwards. Stage 1B, it's not category 1, it's just category 2 recommendation. So now definitely osimertinib is the standard of care. So here we conclude our panel discussion. Are there any queries? Most welcome to ask. So if there are none, so now I would like to invite Dr. Anshul Gupta to give us a talk about management of lung cancer, overview of lung cancer management. Dr. Anshul, sir, over to you.
Thank you, Dr. Kapil. So first of all, my apologies. My session was slated in the beginning. One of my patients threw seizures, so I had to go back. So now I'm here. So I think my slides that have been provided to me, and the topic is overview of management of lung cancer. Okay, so can I share my screen, please?
Yes,
Yes,
you
sir,
can.
please do.
Okay, I believe my slides should be visible now.
Yes.
Okay, so I think Dr. Kapil and the organizers, I would like to ask you, do you want me to go ahead with this presentation? Or, I think because most of the things in this have been covered in the panel discussion that you have taken previously, like the role of PET and mediastinal staging and, this thing, what is
Dr. Anshul, in the panel discussion, we have DM and DNB residents also. So for their exam benefits, so please, if you can just go through these
I will.
slides.
Otherwise, what I was suggesting is, okay, I have a case which I wanted to discuss, which incorporated EGFR TKIs, bevacizumab, as well as this thing chemotherapy in the same patient. Okay, I'll just go through the slides quickly, and then
You can quickly go through these slides in 5 to 10 minutes, and then we can discuss your case. We have enough time, I think.
Perfect, perfect. Okay, so let us just go ahead with this. Excuse me. Yeah. So burden of lung cancer in India, as per Globocon 2020, if you see in both the sexes combined, it is approximately 5.5%. Okay. However, if you see in males, it is the second most common cause in males, being 8% after combined lip oral cavity of 16.2%. If you segregate these parts, then probably lung cancer stands as the most common one. So the same thing. So as rightly mentioned, the difference between AJCC 7th edition and 8th edition is that, specifically when you come to T2 and T3. So if you look at AJCC 7th edition, T2B is less than 5 but less than 7 centimeters, and T3 is anything over 7 centimeters. However, as per AJCC 8, it has downshifted a little, and T3 is 5 to 7 centimeter, and T4 is now currently more than 7 centimeters. Likewise, when we were discussing about the part that what is more than 4 centimeter in this, when Dr. Kapil was discussing. Okay, so these are the investigative tools we have. So as whenever a patient comes to us, I think most of us now reflexly order a PET scan. CCT chest is a reasonable modality for places where PET scan isn't available. For mediastinal staging, we have mediastinoscopy, EBUS, or endoscopic ultrasound. Then, we need bronchoscopy sometimes for the mediastinal, for the central lesions where we cannot do a percutaneous biopsy in such situations. And of course, an MRI brain, which is now more or less standard of care in small cell as well as majority of the non-small cell lung cancer patients. Okay. So a small comparison between CT versus PET for stage 3 NSCLC specifically. So lymph nodes which are more than 1 centimeter, they are quite significant. They're likely to be harboring malignancy. CT scan done alone has significantly low sensitivity of 55% and a specificity of 81%. So, for additional, if we want to increase the sensitivity and specificity, PET CT adds that value, and it leads to the increase up to 90% in both the situations of sensitivity and specificity. Okay. So talking about what are the risk factors for occult N2. Okay. So specifically, if you see this part, that if the SUV max was more than 4, then the percentage of occult mets, it rises from practically 5 times, 1.9% to 10.5%. So that is something that where the PET comes significantly in the picture. Okay. And along with that, if you see the size part of it, as so size and centrally, the increasing size, centrally acting located tumors, they have more and more possibility of occult N2 disease. Okay. So mediastinal staging, I think so we discussed this in the previous slides, that, anything which is less than, which is more than 2 to 3 centimeter or a peripheral and a peripheral lesion. Apart from that, everything else we have got to do mediastinal staging. The choices are multiple. We most commonly we do is EBUS and TBNA with that. Endoscopic ultrasound is something which is coming very prominently now, and more centers are having it. Again, conventional VATS and mediastinoscopy, they still have some advantage, but if you see in the hands of an experienced pulmonologist, I think EBUS is as good as mediastinoscopy in today's time. So a word about mediastinal staging, and there are 14 nodal stations. So station 1 is comprised of supraclavicular nodes, which corresponds to N3 over there. 2, 3, 4 is superior mediastinal. 5 and 6 is aortopulmonary zone. 7, 8, 9 is inferior mediastinal in the subcarinal and the lower zones. And 10 to 14 are hilar and interlobar in the peripheral zones. So the thing is that obviously recommended technique is we have now moved from the invasive techniques to the non-invasive ones, EBUS and EUS. And if clinical suspicion of N2 involvement remains high, even after a negative EBUS, then, you go ahead with the mediastinoscopy as a fallback option rather than as a frontline option. Okay. So again, the same part, when is invasive mediastinal staging indicated? Central location, yes. Size more than 3 centimeter. Okay. Extensive infiltration of the mediastinum with no evidence of extrathoracic disease or a positive N1, then yes. Bulky N2 on CT, but there is no need for invasive confirmation. Okay. And one thing is there. So whenever we go ahead for all the DNB residents in this group, whenever we go ahead with any EBUS, we go to the N3 node first. So if the N3 or the distal most node is positive, then the hilar is positive, then all the other are likely to be positive. Okay. So moving on. So this is mediastinal staging algorithm protocol. I think I'll just run through it quickly. So it is if a PET CT with intrathoracic lung cancer with or without enlarged lymph nodes, if mediastinal lymph nodes are negative and it is N0 with low probability of unforeseen N2 disease, then we just go ahead with surgery straightforward. If it is N1 or there is high probability of N2, which can be again determined by high SUV or the greater size, then you go ahead with tissue confirmation of EBUS and EUS. And mediastinal, if lymph nodes are negative, you go ahead with surgery. If positive, then of course it leads to upstaging of the disease. And if mediastinal lymph nodes are positive at the baseline on the PET, and if it is non-bulky, it is not big mass, then tissue confirmation by EBUS or EUS is required, and we follow the same protocol as this one. However, if it is bulky lymph nodes are seen, then perhaps no confirmation is required, and we can directly proceed to the multimodality treatment, consider them as positive. Okay, so I'd rather not go into this, but simply speaking, see, invasive modalities, they would give you access to most of the lymph node stations. However, as you can see, EBUS TBNA and EBUS FNA, they are there in most of them. So progressively we are moving from invasive modalities to non-invasive ones. Okay, this is the same thing. Coming to just a word about therapy part of it. So NSCLC initially was considered a single disease probably till a couple of decades back. And now, it is just most of the pulmonologists or the medical oncology specialists, they now treat lung cancer as a heterogeneous entity, with each entity having a separate pathology, separate mutations, and separate treatment and outcomes. Okay, so it is imperative that we do the molecular testing at the baseline, and we would we would rather do molecular testing at the baseline rather than do it on progression, specifically in cases where such as squamous as well. Nowadays, most of the medical oncologists are progressively wanting to do molecular testing even in squamous or adenosquamous. Okay, then PDL, on the basis of PDL1 expression, they can be differentiated. On the basis of tumor mutation burden, they can also be differentiated. Okay, so to all the residents or anybody in this group, can anybody tell me, so TMB less than 10 mutations per megabyte or more than 10 is the standard cutoff for solid? Can anybody tell me what is the cutoff for liquid? Okay, so it is usually 16 to 20 is the cutoff if we do it in a liquid biopsy. Okay, so in terms of advancement in management of NSCLC, see, we all know now with the advent of molecular targeted therapy and immunotherapy, the prognosis has significantly improved. And as I said, immunotherapy has taken the bull by its horn, and we have multiple immunotherapy molecules, multiple targeted therapy molecules in the field of lung cancer. So if it is just a bird's eye view of that, and KRAS, EGFR, ALK, ROS, RET, NTRK, HER2, BRAF, PIK3, RAS, AKT, MET, and I think all of these can be potentially targeted. So there are 7 molecular alterations with FDA approved therapy, and more amongst them, even the perhaps not HER2 fusion but HER2 amplification, we can give therapies. And KRAS mutations as well have currently sotorasib, which is there for the treatment. Okay, so this is the broad overview of current guidelines. Stage 1A, we can just do surgery and need not give any neoadjuvant or adjuvant. Stage 1B or 2A, multidisciplinary team discussion needs to be there regarding the benefit of adjuvant chemotherapy. I think less meta-analysis I'll be just discussing. So stage 2B, adjuvant therapy is recommended, and stage 3A and 3B, neoadjuvant or adjuvant or probably sequential is the way to go. Okay. So as we had previously discussed, radiotherapy largely remains, an option where there is margin positive R1 or R2 resection. Otherwise, standard chemotherapy as per the staging we have already spoken about. Okay, so this is just a overall overview of post-surgery. 40 to 50% they remain cancer-free, and 50 to 60% they remain they recur, and the recurrence can be local or distant. A lot of times it is distant recurrence. Okay, so this is the latest ESMO guidelines that recommend that adjuvant chemotherapy can be considered even in stage 1B disease and a primary tumor more than 4 centimeters due to clear evidence of benefit. As you can see, these curves, they separate very widely when this is less than 4 centimeters. Okay, so this is the latest meta-analysis that I was talking about. OS benefit from preoperative cisplatin was there, and there were multiple of partner chemotherapies of platinum which were used, cisplatin, vinorelbine being the most important one. And the hazard ratio was 0.89 with an absolute benefit of 3.9 and 5.4% and 3.85% respectively. So this established the role of adjuvant platinum-based chemotherapy in NSCLC. So how does neoadjuvant work? So if you see from stage 1B to 3A, the hazard ratio is 0.87 and adjuvant it is 0.89. So technically it should work, but yeah, stage 2 and stage 3 are the places where we would like to give chemotherapy more in the neoadjuvant setting. So again, ADAURA trial, we have discussed this. It has improved DFS and brilliant hazard ratios, unprecedented, unheard of in the lung cancer stage. So now it is pretty much a standard of care in the adjuvant setup in the EGFR mutated lung cancers. Atezolizumab has also shown improvement in DFS and in the adjuvant setting. Okay, a word about RT, although I don't think so we have radiation oncologists amongst us. Okay, so newer and newer techniques are being there, and as we were discussing and in our discussion that now even the tumors which are very close to the heart and central and close to mediastinum, we have beautiful techniques, IMRT, IGRT, to eliminate or to significantly lower the dose which is delivered to the vital organs such as heart. So I would skip it because I'm not a radiation oncologist and I would rather not go ahead with it. So chemotherapy with or without radiation therapy, is the standard of care after complete resected patients of stage 3 NSCLC. I think this is a fairly standard statement and we have all come to the same conclusion. So checkpoint inhibition, unresectable stage 3, as specific trial was there, and it improved hazard ratios. As we can see clearly, it separated the curves. Durvalumab, it demonstrated 2.9% OS at 5 years, which is quite good. And this is, when you see historically, 5 years OS is say less than 20%. I would say this says 15 to 25%, but most of the studies, they quote less than 20%. And of course, emerging treatment paradigms, which we have discussed, few of them. And I think lung cancer is something which has now exploded to be the hotbed of all the new targeted molecules and immunotherapy. So again, coming to the FLORA trial in this, PFS with first-line osimertinib versus first-line EGFR TKI in advanced EGFR mutated NSCLC. You see the curve separating brilliantly and the hazard ratio of 0.6, firm and well established. Likewise, the ALEX trial, first-line alectinib versus crizotinib, you see there's a huge difference between the two and a hazard ratio of 0.43. So other molecules, of course, crizotinib is there for MET exon 14 alterations or MET amplification, cabozantinib and vandetanib for RET arrangements, NTRK, of course, larotrectinib and entrectinib, and HER2 mutations, and not amplification, TDXT or adotrastuzumab emtansine. Of course, trastuzumab deruxtecan is also the new kid in the block, which is targeting HER2 mutations. Okay. So survival, again, traditionally it was said that, with platinum doublet chemotherapy, survival is approximately 10 to 11 months. Now it has significantly improved with all of these. And I think ALK positive ones, in whom we give alectinib and lorlatinib perhaps, the survival is almost practically 5 to 6 years, which was unprecedented in cases of lung cancers. Previously, half of the patients wouldn't even, get it tested, get it treated, thinking that, they don't have too much life. Again, immunotherapy, CTLA4 blockade and PD1, PD-L1 axis blockade has been the two pathways which have been utilized for immunotherapy checkpoint inhibition. And this is just a historical perspective. 2015 was first time when, pembrolizumab was approved. And now I think we have so many, with the latest being semiplimab. And all of the pembrolizumab, atezolizumab, and nivolumab, all the immune checkpoint inhibitors which have been approved, and not to mention nivo plus ipi combination. Okay, so survival again with immunotherapy, it has gone up to 1.8, 1.5 years to 2 years in most of the situations. So this is the same thing. Okay. So checkpoint inhibition in early stages is also moving ahead, as as we had mentioned, the Keynote 091 trial it involved pembrolizumab, IMpower 0101 trial, atezolizumab, and Durva and Nivo as well. Okay. So multiple trials are ongoing. Pearls and Pearls trial specifically has shown pembrolizumab to be effective. ADCs, of course, this is something these are the molecules of the future. So we have seen trastuzumab deruxtecan being the game changer in the breast segment, and even in non-breast histologies which are HER2 mutation positive.
Thank you, Dr. Anshul, for this wonderful presentation. Am I audible?
Yes, sir, you are audible. Dr. Anshul, I think this guy has been
got disconnected, I think.
Yes, sir, yes.
Yeah, so I think most of the presentation was complete. It was a lovely presentation to have an overview about overall diagnosis and management of carcinoma lung. So I think it was a lovely presentation. We learned about the liposomal preparations of docetaxel and how it is useful in preventing the toxicity. Then we learned about some overview of lung cancer, and then we had a discussion about EGFR mutated lung cancer, and we had a wonderful discussion. So I like to thank all our sponsors, AstraZeneca, Intas Oncology, and Zydus, to have this wonderful opportunity for the dissemination of information. And with the ADAURA trial OS data coming up and osimertinib becoming the standard of care, so I think it's a wonderful opportunity for AstraZeneca and for all to improve lives of our cancer patients. With this, I would like to thank all our sponsors, and so over to you. Over to you, Arham.
And thank you so much, sir. So can we close the meeting, sir?
So good night, everyone.
Okay.
Yeah.
Thank you
Good
so
night,
much for
Dr. Kapil,
joining
sir.
in. Good night.
Thank you, dear. Okay.
Thank you, sir.
sir. Thank you, sir.
Support team, please close the meeting.
Okay, sir. We are offline now.
Okay, thank you so much.
Okay, thank you everyone. Thank you so